So in the adjuvant treatment of melanoma at this point, we kind of, I wouldn't say suffer, but we have a bit of an embarrassment of riches. Finally, we have several therapies that can actually improve our patient outcomes and are safe and tolerable. So again, to just go through those therapies, we have two single-agent anti-PD-1 antibodies, nivolumab and pembrolizumab, that have proven safe, about 15% grade 3-4 toxicity, and highly effective, decreasing the risk of recurrence by about half, with a hazard ratio that kind of in the range of 0.5, in the range of 0.5. And then we have targeted therapy, which is at this point the BRAF-inhibited trametinib for patients that have a BRAF mutation, and that decreases the risk of relapse by about a half. So it should be noted that the 3 different studies that were done to prove or to approve each of those 3 therapies were different. Pembrolizumab was compared to placebo, whereas nivolumab was compared to active therapy with ipilimumab. The BRAF-inhibited trametinib was also compared to placebo, but none of these 3 agents were compared head-to-head. So all that we can do at this point is to kind of get a general sense of how effective they are. And as you heard me say, they all have about a kind of a 50% reduction in the risk of relapse. So really, when we have to make a choice in the adjuvant setting, the first thing I always do is actually test for BRAF, because I feel that that's an important consideration and an option that our patients should know whether they have or not. So I tend to insist on getting the BRAF result before we start immunotherapy, although I have patients that feel strongly about receiving immunotherapy. They're clear that they don't want to have targeted therapy, so I wouldn't delay their therapy specifically for that. But generally speaking, to have a fuller conversation with your patient, I think knowing the BRAF result is very important. And then we have the conversation. And that conversation is now extended at this point because we share with them all of the data, basically again highlighting the fact that with immunotherapy you have a decreased risk of relapse. The grade 3-4 toxicity is only 15%. Most of the toxicities are manageable. And there have been no deaths on study from immunotherapy, which was not the case with, say, ipilimumab. However, what we always need to highlight to those patients is that some of those toxicities are actually long-lasting toxicities, specifically endocrinopathies and sometimes neuropathies as well. So that's kind of an aspect for someone that you're trying to cure, and that actually could actually be cured with surgery alone. So there's a chance that your therapy may not have been needed. We feel pretty strongly about not giving those patients too much toxicity. And so that is always a discussion with the patient. When it comes to targeted therapy, we point out to the fact that actually it seems in general more toxic than immunotherapy. We have about a 30% or slightly higher than that rate of grade 3-4 toxicities, and 26% of patients actually stop because of toxicity. However, the difference, and that's where you kind of have some differential depending on patient's preference, is that the toxicity from targeted therapy actually stops the minute kind of you stop the drug. So it's very limited in time, and it doesn't induce any long-term toxicities. And so with those, kind of choices that patients have, and with this kind of overall discussion of what the benefit is and what the toxicity is, that's kind of how we end up making decisions with patients. I would just kind of want to share with you that as we were designing the next adjuvant trial, I tell my patients that I am actually comfortable flipping a coin and deciding which one they go for, because technically there is no proven difference in efficacy. So from an efficacy perspective, these approaches seem to be, kind of equally favorable. The concept of whether patients are compliant with their therapy, with targeted therapy, is a really important consideration. We've learned that from the early days of even Gleevec and GIST and even in CML. So we really kind of tried to highlight that fact that patients need to adhere to their therapy. In the adjuvant setting, that's probably even more difficult because patients know that they're taking it for kind of prevention of the risk of relapse. So it's not that they're treating an active tumor, and that's kind of, I think, plays on the psychology of the situation. The way we handle this most of the time is really our patient. We tell our patients to communicate with us in case they're having toxicity. They're most of the time are not going to be compliant because the drugs are not making them feel good. They're giving them fevers, fatigues, fatigue, some of the side effects that are, not pleasant. And so that tends to be the major reason. And so we always discuss with our patients whether the first step would be to actually decrease the doses or modify the doses so that they're more tolerable with them. But in general, I don't think that we have data that's very clear about how much those patients comply with their therapy, at least in the adjuvant setting.